right, we can get started. Hello,
Okay.
welcome to Grand Street Rounds. I'm your host, Dr. Carlene McMillan, and I'm the CEO and co-founder of Brooklyn Minds. We offer comprehensive mental health services and are based in New York City. We specialize in treating patients as a team for whom more traditional psychiatric help, such as the heavy use of frequent hospitalizations and crisis emergency room visits, has often been counterproductive. Grand Rounds, for those who don't work in medicine, originated as part of residency training to share new information and enhance clinical reasoning skills. Grand Rounds help keep people up to date on bigger picture ideas that may be out of someone else's area of expertise. Grand Street, for those who haven't visited our Williamsburg flagship office, is our first permanent home, so the mashup was a natural fit. Today, I'm very excited. We welcome Dr. Owen Muir, who is, along with me, the co-founder of Brooklyn Minds, and he's also our Chief Innovation Officer. He's an adult and child and adolescent psychiatrist, and today he'll be speaking on mentalization based treatment. This is a topic near and dear to my heart, as it's the core of what we do here. Dr. Muir is one of a handful of official MBT supervisors in North America in mentalization, and he has additional training in using MBT strategies with adolescents, families, and even teams and systems. He's also the co-editor of a just published book entitled Adolescent Suicide and Self-Injury, a Mentalization-Based Treatment Approach. He talks about mentalization and other mental health related topics on his 2 podcasts and oversees our pioneering transcranial magnetic stimulation program. We get a lot of questions about what this MBT thing is all about, and I cannot think of anyone I would rather have answer than him. Before we begin, just a reminder that the content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your mental health professional or other qualified health professional with any questions you may have regarding your condition. So after Dr. Muir's presentation, we'll have question and answer time. And thanks to those of you that already sent in questions. But if you have additional questions, please feel free to put them in the chat throughout the talk or send them privately. And hopefully we will get to them after his talk. All right, so welcome everyone. Thanks for being here. And Dr. Muir, turn the Zoom over to you.
Thank you so much. This is an introduction to the ideas that drive the work that we do at Brooklyn Minds, mentalization based treatment, and the curious stance that is at the heart of that. I am a medical doctor, and I went to med school to learn how to use medicines because I thought, wow, this is going to be great. I'm going to fix all my patients' problems. And it turned out to not be the case. When mentalization based treatment came into my life, I realized I had this whole other realm of tools in really specific psychotherapies that weren't being broadly utilized in the US. And I thought, like, well, I guess I'm going to have to get good at this because no one else seems to be doing it. And it seems to have, been building steam since then. My favorite teacher in medical school, Jeffrey Linus, told us, when you have a lecture, tell them what you're going to tell them, and then tell them what you told them. So I'm going to try to have that format today. The first thing we're going to do is define this very wonky word, mentalization. And we have to define it in a couple different ways. The nice thing about it is no one has any idea what you're talking about when you use the word, so you're really free to set that definition in a way that makes sense to your audience. We're going to talk a little bit about the basis of attachment as the theoretical construct that allows this process of considering the minds of others or mentalizing to take place. And later in the talk, we'll talk about how mentalizing goes wrong and how we might be able to consider what's happening in people who have difficulties with this as disorders of trust. Mentalizing is fundamental to being human. This is my daughter, Quinn, and she's 4 months old in this picture. And she's already learning that she's a person and that her caregivers are people. And when you look at your parent or caregiver when you're a child and you get that response back, oh, are you sad? What's going on? Someone trying to work out what's going on in your mind. That's the beginning of the process of mentalizing from that very early age before we have any language. Defining it, we do in a couple different ways because mentalizing is about alternative perspectives. So one definition is seeing yourself from the outside as others might see you, and then being able to think about how you could see someone from the inside as they see themselves. Understanding a misunderstanding, working out how we could have gotten that wrong. Oh, you were on the other Starbucks on 3rd Avenue. Neither of us stood each other up, and we were both very upset that we got stood up because there are 2 Starbucks on this block, not 1. the ability to hold the mind in mind and recognize that what's going on in your mind has something to do with how we behave. And this ability to consider other minds comes from attachment. I actually have twin children, Trent and Quinn, and when they were very young, they've been together, from day one, and they've really learned a lot about minds from interacting with each other, again, before they could even talk. Now, this word attachment's been misunderstood. Attachment parenting is very much not what attachment theory is about. And this is all based on John Bowlby's work from the 1960s and followed up with the invention of the video camera with empirical research from Mary Ainsworth and later Peter Fonagy and others. And when we're talking about attachment, we're talking about something that we can see as early as 1 year old is when Mary Ainsworth did her hallmark studies, the strange situation paradigm. And what we saw is that the styles of attachment we saw, how kids related to their caregivers and parents, predicted how they're going to act later in life, 21, even into your 30s. And what this attachment style predicts is how you're going to respond when close relationships are hurt, separated, or perceive a threat. Because some people freak out when they think something's going wrong. Even the idea that they might be abandoned can be devastating. Harry Potter did not have the most normative experience growing up. Hogwarts is, to my understanding, full of difficulties most kids don't face. And so the Harry Potter Legos here are my attempt to illustrate some of attachment ideas, starting with secure attachment. And this is what happened in the experiments when the kids had the mother leave and come back, and mom came back, and they're able to kind of touch base with mom and then go back to playing. And for you to have secure attachment develop in your child, you only have to get it right. You only have to understand their emotional state about 30% of the time. It's a little bit like baseball, a good RBI of 0.333 or whatever. That's good enough. And so we're not shooting for perfectly matched parenting with the child's state, and that would actually be bad because there'd be no misunderstandings to work out. So good enough is really what we're shooting for. This is a brief tour of insecure attachment, which is, of course, the other flavors from secure attachment. And we're going to let anxious attachment lead us off. So in the strange situation, Mary Ainsworth had the mother leave the room, and there was a stranger in the room. Mom comes back. And importantly, what you're going to see in all of these cases of insecure attachment is the same underlying physiology. So all the kids had their heart rates going through the roof when the parent came back. But how they acted was very different, and you might not even be able to tell they're in distress physiologically, visually. In anxious attachment, the child goes back to the caregiver and hugs and just never lets go. Almost can't be consoled. Avoidant attachment, the caregiver comes back in the room, but the child seems to be uninterested in mom's return. Now, again, that heart rate is through the roof. It's the same underlying physiology, but the behavior is quite different. So they've learned, I'm getting nothing from this caregiver either way. Why bother going for them to get support? And disorganized attachment, which I clumsily try to illustrate with Legos here, is when you really have no predictability in what's going to happen, what kind of response you're going to get from your caregiver. So we have marked contingent mirroring. Oops, sorry. Fix that. That when you're looking at your kid and your kid is crying, and you may say, "Oh, what's wrong?" And that's contingent. It sounds sad, but it's not just, "Why are you crying? What is wrong?" That's contingent. You're both sad, kid and parent, but there's no emphasis that lets the child know there's a different mind interpreting their mind. There's really no barrier there between them. And that's why depressed mothers can have some really, bad outcomes when raising parents, and why we take depression in mothers and perinatal psychiatry so seriously at Brooklyn Minds. It can look pretty rough in your office. And this patient was an adult fan of Lego in their, late 20s, and, still kind of a wreck after the session. So this is something that does persist over time. When we're thinking about what it's like to have your attachment system be aligned in a way that leaves you either avoidant or disorganized or anxious, we're thinking about what can you learn? What kind of social information was it adaptive to learn for you early in life? And this is not a good idea. We'll have to deal with that. How long does it take to learn math? That's right, all the years. And how long does it take to learn to trust mom when she says, don't go with the bad man in the free candy van? That's generally instantaneous. And if we think about it, it's really similar levels of complexity to long division in terms of the information you need to process. Like, is free candy something that would be normative in this context? No. Stay away from vans that advertise something we don't expect. But we do need to learn some very complicated responses very quickly. And the way we do that is by having an attachment system that lets us understand certain information as immediately important to the self. This can be used against us. In situations of chronic mistrust, like George Orwell's 1984, the government intentionally created an environment where people couldn't trust the information they were getting. And getting, 2 + 2, what's the answer? 4. Wrong. What's the answer? 4. Wrong. What's the answer? 5. Wrong. What's the answer? 4. It's 4. What's wrong with you? And that inability to predict what's gonna be the answer when we really all know what it is, that can generate tremendous mistrust. And that's the message a lot of kids are getting early in life from disorganized attachment relationships. Is this drug dealer in my house someone I should be trusting? Well, my mom sure seems to be close with them, etc. That can really create confusion in what to trust or who to trust. So, when we're thinking about an organizational perspective, which we do a lot, when we're bringing in new information like this to you, we want to use trusted sources when possible. And hopefully I'm the trusted source today. I seem to be passionate about this and all that. It makes it easier for people to take what I'm saying and use it in a way that's useful to them. What's the goal of mentalization-based treatment? When we take these ideas about attachment, we turn them into a treatment. Well, luckily, it's really simple, and this is why I loved learning MBT. If someone's not mentalizing, you get them mentalizing. Being able to understand a misunderstanding, work out what's in someone's mind. And if they are mentalizing, you keep them mentalizing. That's it. There's no insights, there's no skills other than being curious. It's really one thing, and that makes it, for a simple person like me, easy to keep track of. Like, yes, no question is what's driving an entire, therapeutic treatment, paradigm. I don't have to think about much. It's just yes, no, mentalizing or not, then how we get back to that. The mentalizing stance, which is illustrated here by the remarkable Sarah, our intake coordinator, featuring Milo, the dog, and Columbo, the curious cat. And it illustrates the 4 legs of that stable structure that is the mentalizing stance. We start with an inquisitive and
and I
not
think you
knowing.
need to go to the next slide. Sorry.
Okay, I can. It comes back again. The idea is we want mentalizing to be online when it should be. Now, there's sometimes when your emotions are too hot or too cold, and it doesn't make sense to mentalize. You don't mentalize everyone who walks past you on the street. That would be exhausting and pointless. And similarly, you don't mentalize tigers who are coming to eat you because it's not adaptive to spend your time. I wonder how hungry he is. Run away. You're going to die. It's a tiger. When we get too hot, we have predictable ways of reacting, and our minds will work differently in ways that are adaptive in certain contexts. So your feelings can equal the facts. I know that tiger is hungry. I'm going to run now. And, you can even elicit proof from your environment. I need to know if you care about me, so I'm going to make sure you prove it. So I don't have to wonder if I can trust you. You're going to prove it to me. Similarly, on the too cold side, what the manual in the UK calls pretend mode, and whatever mode is what I sometimes call it. We have a horizontal axis with a number of fucks given, right? How much do you care? Because if you care a lot, this is not a good space to mentalize. If you don't care at all, you're probably not going to be able to be curious either. So that mentalizing ability really does how much you care. And I use that, swear word because it, was appealed to adolescents. And they're like, I didn't expect a doctor to say that. It's challenging to their mind and gets into a space they wouldn't expect, which makes curiosity easier. The most crucial is not knowing, which doesn't mean we're clueless. It just means we're not sure. And we really want to make attempts to get it right, iteratively. And again, that brings us to the mentalizing stance. We want to highlight good mentalizing when it occurs, stop non-mentalizing when that's happening, and hold the balance between the polarities that can exist. And so mentalizing isn't about being stuck on self or other, inside or outside. It's about being able to smoothly transition. What did you imagine was happening for me? And if the person can answer you, they can go from their story about themselves to one about my internal state, then mentalizing is probably happening. Similarly, there's a balance between certainty and doubt, and feelings and cognitions, more kind of concrete thoughts. And it's not about being all the way on one or the other. That's generally unwell. There are only 3 non-mentalizing modes in the whole model, which is awesome because I only have to remember 3 things. We want to recognize these non-mentalizing modes because in the treatment, once we recognize someone's not mentalizing, we know what to do, which is get them mentalizing. So what it looks like is in this mode, psychic equivalence in the manual or feelings equals facts. There's no doubt. I know what's going on here. I am certain I do not need your help. Thank you very much. It's just because of the accident. And when people's feelings equal the truth, I know you hate me. Then they don't really need any input from the outside world because what's in their mind is what's true in the world. And for clinicians, we can feel, or anyone in your life, can feel fed up or confused, want to argue with the person or not even know what to say when they're in this mode. And so there's some good ideas like validation, helping someone feel understood. And you get there by being curious. I wonder if this was hard for you, as opposed to the kind of more standard therapy trope. This must have been hard for you. The problem with that statement is it may be empathetic if you're right, but it might be hard for you allows them to correct your understanding. And so you steer away from those landmines of getting it wrong, which patients won't even always tell you. They'll just not trust you. Being confused is a great response because it's probably genuine when someone's feelings equal the facts. What? Hold on. I'm not following is a really gentle way to challenge an idea. And sometimes you can't stay on it. There are some people who have beliefs that are fixed. And anti-vaxxer debates, for example, often have people with very strong feelings one way or the other, and debating them isn't going to change anything. So distracting them from that particular fixed idea to something else is generally a good idea. Making it worse, arguing, debating the facts generally doesn't go well when people are in this state. Getting really cognitive, yeah, but if you think about it for real, you'll see. And getting angry and non-mentalizing yourself, calling 911, kind of punitively, etc. That generally makes things worse in the long run. On the too cold side of the equation, when you just don't care enough, that looks like someone just talking forever. I did try to kill myself yesterday, but I'm fine now. Yeah, no, it's fine. Thanks for asking. It's really nice of you. I use my skills after the fact. I mean, I didn't use them at the time. Never do that. But now I'm using my give skill and my fast skill, and things are great, right? I am the best mentalizer, holding incompatible ideas at once. I just have no idea what other people are thinking. And having feelings and words that don't match. When you heard me describe the suicide attempt and it sounded like I was talking about, picking up the newspaper on Tuesday, that's not what it's supposed to sound like. And so our own internal experience of feeling bored or detached from the patient, that is evidence that pretend mode is what's happening. So you don't have to feel bad about feeling bored anymore. It's information that you want to tune into. Also, thinking you're doing a really great job may be a flag that you're kind of collaborating in this pretend interaction. Like, man, they're using all my therapy skills. This is awesome. I'm so good. Uh-oh. And it really kind of just meaningless words and endless agreement, signs that things may be awry. This video is a great example of pretend mode. And I think it would be a pretty good session if they actually said what they were saying in their minds to each other.
Hello. Welcome back, Melinda.
Getting the
I
audio
will
on that?
ask you how things have.
Do we get that? No?
That was working.
No, it was? Okay.
Hello. Welcome back, Melinda. I will ask you how things have been going and then get internally frustrated that you are rambling on about things that are boring. I am doing fine. No, I'm not. I'm really mad at you, but I won't say so. Instead, I'll complain about how nobody cares about me and justify my bad choices by saying that it's my mother's fault. I will nod and smile. I will also ask you vague questions about how you feel because I can't remember any other responses. I will also comment over and over on how things must be hard or difficult for you. You will not feel understood. I will get really quiet and not answer your questions. I think you're only here for the paycheck and that you go home to a perfect life in a big house with a pool. I resent you. I'm trying to remember what my supervisor suggested I do when my clients get upset with me. Since I can't remember, I will get defensive and say we are here to focus on you, not on me. I'll start talking about how I wish my boyfriend would get a job so
Owen, it stopped.
Yeah.
Hello. Welcome back, Melinda. I will ask you how things have been going and then get internally frustrated that you are rambling on about things that are boring. I am doing fine. No, I'm not. I'm really mad at you, but I won't say so. Instead, I'll complain about how nobody cares about me and justify my bad choices by saying that it's my mother's fault. I will nod and smile. I will also ask you vague questions about how you feel because I can't remember any other responses. I will also comment over and over on how things must be hard or difficult for you. You will not feel understood. I will get really quiet and not answer your questions. I think you're only here for the paycheck and that you go home to a perfect life in a big house with a pool. I resent you. I'm trying to remember what my supervisor suggested I do when my clients get upset with me. Since I can't remember, I will get defensive and say we are here to focus on you, not on me. I'll start talking about how I wish my boyfriend would get a job so that I don't have to keep working. I hate working and think I should just be able to do whatever I want with my time. I work 50 hours a week in this job and I teach part-time at a community college. My husband left me when I became a therapist because I wanted to improve our relationship and he was too threatened by this. I am exhausted and I only make $35,000 a year. I would like to do whatever I want and be supported by someone too. I won't tell you this, but instead will judge you and ask you a question that will make you defensive. How is it fair that he has to work but you don't? I will cross my arms and look away. I will say, I don't know, rather than responding to your question. I will sit in silence for an uncomfortable amount of time. I am uncomfortable with silence and don't know what to do now. I will look at the clock and hope our time is almost up. It isn't, so I will ask an unrelated question and hope you just talk for the rest of the time so I don't have to do anything. How are things going with your mother? I will spend the next 20 minutes complaining about how I hate my mother and I will branch off into a story about my new dog, Punk, Boy. I am going to put a service dog jacket on him and take him wherever I want even though he has no training, chews on furniture, and has been known to bite small children. I think that is a bad idea, but I am afraid that I will violate disability regulations if I question your plan to pass an untrained animal off as a service animal. Instead, I will say something encouraging. It sounds like Punk, Boy, is a good support for you. Yes, he is. I will tell you more about him and will avoid any talk having to do with my therapy goals or personal responsibility for making my life better. You will nod and smile until our time is up and put in your case notes that I am unmotivated and resistant. I look like I'm listening, but I'm actually thinking about what I need from the store and whether I'll have wine, or maybe whiskey, tonight. I really like whiskey, okay, that's about it. I'll commit to seeing you next week, but I'll actually no-show for 2 more times and not return any of your calls. I will then tell my probation officer that you never return my calls. I will be happy that you don't show and will use my free time to update my Facebook page. Have a good week. You too. Thanks.
Now, that's intended to be humorous. I always think if they actually just had their minds open to each other and shared the things they were thinking, that would have been a great session. And the model in MBT is not, kind of no filter, but it is to keep our minds open to each other. Like, I'm not feeling connected to you right now is something you kind of can say in an MBT context that might not make sense in other therapeutic contexts. When people are in pretend mode and, it's kind of too cold, there are ways we can act to get out of that. And that video you saw before was a lot of pretend mode. It was people thinking things and not saying them. There was an elephant in the room. And the elephant was how much neither of them were very interested in the interaction they were having and were much more attentive to the criticisms they had of each other in their head. And so ways to get out of that or probe the depth really is that you just feel fine. Challenge can be anything that kind of trips your mind up. And so, my favorite example of this was our colleague Ian, who in a room full of kids who were really acting quite badly, jumped up on a table and yelled, "Cowabunga," which was not what they were expecting. And everyone just kind of dead stopped. Bringing it into the here and now with us, not there and then with them, is a really good way to increase that emotional temperature and really get the number of, the amount of caring about the situation up. And that helps get things to a more curious place. And then addressing the shared dilemma. It seems like you really don't want to be here. And I can pretend to do therapy stuff with you, but if you don't want to be here, does that make any sense? I feel like I'm, not doing a great job as a bad doctor. The ways to make it worse, what we call iatrogenic, we did it harm in medicine. Non-recognition that it is pretend mode, accepting it as real, and using that time to teach skills or have some brilliant insight. It's really about your mother. Yes, you're so brilliant, Dr. Muir. Thank you. This is, Curb Your Enthusiasm is basically a show about non-mentalizing in humor format. And here we have Larry and his therapist having a conversation where they, are looking for a little proof.
Interesting to me is that I find you're focused on the number of women who apparently are very interested in you, and yet, Larry, you seem preoccupied.
I'm just wondering, have you ever noticed the disparity in these two chairs? Your chair is so much better than this one. This is not a comfortable chair at all. Did you buy these chairs?
Yes, I bought both of them.
You picked out both of them?
I picked them out, yeah.
What was going through your head when you picked out this chair? You picked out a great chair for yourself. That's a gorgeous chair. I would have that in my house. But this one, it's not comfortable. I'm constantly shifting from side to side. You have the comfortable chair. You have taken the good chair.
It's interesting. You are the first and only patient who has ever said anything negative about that chair.
I don't find that interesting at all.
Well, I do, and that's my job, to find things interesting.
Well...
Interesting with the chair.
I don't know what you're writing over there.
Chair issues. I think there's something deeper.
I don't think you're writing anything. I think you're...
No, I could show you.
Huh?
I could show you.
I mean, you're a nice man, but, do you do that much between you and me?
Don't you think that I do a significant amount of help to you?
Yeah.
Really?
May I be honest with you?
I hope that you can always be honest with me.
Well, I'm often never honest with you, but here's what I'm proposing. I think you should go chair shopping. I think you need another chair. And you know what else? I'm willing to go chair shopping with you. Will you think about it?
I don't know, but I do know that the session is over, and so we'll have to pick this up next time.
It's tough for you to have to look at that watch, isn't it? It must be a little awkward. You know, I see it.
I know you see
can't
it. I'm
sneak a
not trying to sneak it.
You can't. You're trying to do a little sneaky watch peek.
I'm not trying to do a sneaky watch peek. I'm trying to be efficient with our time.
Why didn't you put a clock behind me so you could have a clock? You know when the time's up. But
Nevertheless, it is over, and I'm looking forward to seeing you again next week.
So you got big plans for the weekend?
This weekend and all through next week, my wife and I go out every single night to a different restaurant because it's truffle season. It's wonderful. Do you like truffles?
No, I loathe them. They're disgusting.
Oh,
To each his own.
to each his own.
Yeah.
Okay. Thank you, Larry.
Okay. And by the way, anytime you want to get rid of me as a patient, just say I've had enough. It'll be okay with me.
Oh, dear God.
And you may have noticed some mistrust in that interaction, some need to have things proved. But what wasn't happening was an acknowledgement that, you know, when the psychiatrist said, like, don't you think I do a significant amount for you? He wasn't imagining Larry's mind, which was, not really. And they probably had been doing that dance for quite a long time. Prove it mode, or teleological mode, in the British version of the manual. When we're recognizing that happening, it looks sometimes like crazy actions, like ripping up every floor tile in the hall of the psychiatric unit. We can only understand outcomes as motivation. So I know my therapist cares because when I ripped up every floor tile, I got a phone call at midnight. So now I know they care and I can stop doing it. Not being able to understand without proof. There is an inverse correlation between the size of a wedding ring and the duration of the marriage. And, you know, I don't know that this is based on mentalizing, really, but it may be that if you need a lot of proof, it may be for someone who doesn't have as much reflective functioning, and things may go wrong. And finding yourself kind of doing, you know, just another prescription. Finally, my doctor prescribed the medicine. I asked for Risperdal for months, and he finally gave it to me. I know he cares. Our experience can be really anxious and having a wish to act, feeling shocked or uncertain. And that's evidence, again, if we're feeling that kind of freak out, that, oh, we're in prove it mode. That's why. And so oftentimes validating the need and addressing the elephant in the room, like, I know you want me to prescribe Risperdal, and I know you feel it'll help. And I also know it causes really significant weight gain, and I'm worried if I give this, it's going to be more harm than help. And so I want to make you feel better, and I want you to, more importantly, understand I know what you need, but I'm wondering if this is the right way to do it. And it seems like kind of we're stuck, maybe. Making it worse, excessive doing. We'll always go 10 seconds over. Well, I'm not going to look at my watch in the session at all because I'll get a clock behind, have this elaborate clock set up so you never have to wonder what I'm thinking and you never have to know that I'm checking the time for the end of the hour. Proving that you care, can only go so far, and trying to problem solve when really we need to get mentalizing back online is rarely helpful. The superstars of non-mentalizing, Larry and his therapist, go and look for a new chair together, and you'll see there's some mentalizing, there's some misunderstandings that get understood in a way that we all get to laugh at.
I gotta tell you something. I never thought I was gonna get you down here.
This is nice.
Let's see.
Try that. What do you think?
Yeah, I don't think so.
I don't think so
No,
either.
not this
No.
one. This isn't bad. It's a bit of a rocker here.
Let's move to another chair. All right.
All right, I gotta say, this one, to me, is a perfect chair.
I think my clients would like this.
Great.
Why not? Well, let me... Oh, it's kind of pricey. Well, thank you. Thank you very much. It's very generous of you, Larry.
Are you expecting me to pay for this chair?
That is all the time we have. And so I'll see you next week. Okay. Thank you, Larry.
Oh, that was a session. Ugh, awkward. There's the term personality disorders, and in some quarters this gets kind of a bad rap. I like to kind of equate it to having acquired mistrust in social information. So when people don't trust what they're hearing because they learned not to do that, it's dangerous. That's what we often see as the kind of instability in interpersonal relationships, sense of self, identity, empathy, that we have referred to as personality disorders. And it may be there's a problem with trust, and you don't know what information to trust, and maybe you trust some information too much and others way too little. When we're looking at how mentalization-based treatment as a model would see, problems, we start with the general psychopathology factor, or P factor. And that's a combination of biological predisposition and early attachment disruption. And often there's trauma, or worse yet, neglect followed by trauma. This can lead to chronic, or what we call epistemic, mistrust in social information. Add some stress, and then in real time, you're getting mentalization failures, and you can get in a lot of trouble. One of my patients really summed it up quite nicely. I have a problem with trust. People say nice things, but I have alternative facts in my mind. Why are they lying to me when they say I look so nice? And so often there's an elephant in the room, and this is our literal elephant in Williamsburg, who we often bring out when there's something we feel that isn't being spoken of. The basic schematic for what you're doing in therapy is really simple. First, you're checking in with your own mentalizing. Is that online? Because it has to be. The answer is no. Hold on a second. I got to check myself for a minute. I'm not following, right? And so you get your own mentalizing back. If the patient is online, will you continue that curious focus on the internal world, and it will probably be a very pleasant session. If you identify the patient is not mentalizing or offline, will we identify which non-mentalizing mode is it? Is it too cold, whatever mode? Is it too hot? Are there feelings equaling the facts or proving it? And sometimes more than one at once. And then we either heat it up or cool it down to get where we need to, validating to cool things down, bringing it to here and now with us to warm things up, and that gets mentalizing back online. And that's an iterative process that we do over and over again. When I've worked with staff members in hospitals to teach this technique, I often get comments like, MBT helps me understand how to approach the kids better and my personal life also. So I refer to MBT as kind of a lifestyle choice to not know, not so much a therapy, but really a different way to think about going through the world. One of the concepts that is important and sounds kind of wonky is the idea of the alien self. And Peter Fonagy refers to this as the internalized representation of a malevolent caregiver. Or as one of my patients put it, their emotional pest secretary who's feeding them bad information and spin. And this discontinuity leads to self-injury, suicide attempts, mentalizing going way offline, and chronic mistrust. And when you have that kind of distrustful self running the show and feeding you information that's bad, you can see why people would react in ways like, I just gave them a compliment. Why are they acting so weird? Well, because it sounded to their emotional press secretary like a lie. And externalizations of the alien self can happen. And this is how some people can get others to act out the part in the play. So if you feel like you're under attack, your world doesn't make sense if no one's attacking you. And it actually feels better and more coherent to be under attack than to not be under attack if that's how you feel. And so often you'll have people with this kind of externalization process going on, kind of picking fights and getting someone else to throw the first punch so the world makes sense. I thought I was under attack, and here it is happening. Now I can defend myself. Boom. This is where duels came from. This is how we get the end of many Shakespeare plays. This sort of thing happens. I think Shakespeare is very attuned to personality as part of the human experience. This is one of my favorite moments of epistemic trust in what I was teaching with mentalizing. I was working with the teachers in the state hospital setting, and I walked in one day about halfway through the year, and they had all purchased their own copy of the MBT manual. This is before I wrote one, and had it on the table for me with a highlighter to prove to me how much what I was teaching them was valuable to them, and that was really meaningful. So kind of reviewing, telling you what I told you. This is developed in attachment. I didn't talk about specific diagnoses because this is transdiagnostic, and there are different ways it shows up in different diagnoses. Oftentimes there's more than one could make, and this works as a treatment by restoring trust, or the ability to build trusting relationships. And that's how people's lives get better. This leads to less impulsivity and behaviors that are less kind of out there. And importantly, most people who are doing this worldwide are not master therapists. They are direct care staff, nursing. This is very popular across Europe and in Australia. And it's average folks who are not, mentalizing Jedis, who are using these very basic tools of just, when they don't get it, not getting it, to work with people who are having a really hard time. If you're looking to start using this in your practice or in your life, I would think about relentlessly validating people. I have this oil rig here because people will say, well, I did the validation. I said I understand that this hurts. And what I would say is if you have an oil rig and you drill down 5 feet, you haven't drilled for oil, right? There's no oil coming up. There's no black gold. That's not enough validation to count as validation. You really need to get to a point where you actually understand what might be going on for someone and they feel understood as well. So stopping at that must be really hard for you generally doesn't go well. Relentless in our attempts to validate. And we're going to close it out with a video by JP, who is talking about how to get offended. And so this is kind of the instruction manual for how to not mentalize.
I've been having life-changing results since I learned how to get offended. Now when people don't see things the way that I see them, I just get offended. And it teaches them how not to see things from their point of view. I'm offended that you would think you have the right to post that to your Facebook account. People have every right to see things from their perspective, as long as their perspective is the same as my perspective.
Here's a water for you.
I don't drink out of plastic. Why would you not know that? People who don't get offended are insecure, take no self-responsibility, and have no sense of purpose in life. I pray for them.
JP, I don't even know why you're offended.
I'm offended that you don't know how you offended me.
JP, I wanted to thank you and show my gift of appreciation by giving you my book, because I know you need it, right?
You're just assuming that I know how to read? There's 3 easy steps to getting offended by anything. Step 1, listen to what someone says, and then selflessly make it all about you by taking it personally, even if it has nothing to do with you.
I really want you to have a great life.
You're assuming my life isn't good enough the way it is? How dare you? Step 2, you want to create a large amount of tension inside your body. You really want to concentrate on bringing the tension to your stomach, your chest, and your face.
How are you doing today, JP?
I'm offended that you would have to ask. Step 3, now project outrage onto the other person. This will make it seem like you're getting rid of the tension inside your body, but it actually drives it down deeper inside you. And because it stays there, it'll make it even easier for you to get offended next time. I'm offended that you would wear that shirt.
I'm actually a little offended by that.
I'm offended that you're offended by that. Since I've learned how to get offended, I bring huge amounts of joy to everyone in my life. People feel like they're free to just be themselves when they're around me. I'm just happy I can make such a big difference in the world.
I think she's a pretty attractive woman.
I'm offended that you would think I'm attracted to women.
Aren't you attracted to women?
Yeah, but you have no right to just assume that. I'm offended that you don't have my new book yet.
When in doubt, do it wrong and then recognize you did. Mentalizing isn't about doing it perfectly all the time. It's about doing it good enough. And when you screw up, I don't know that I was mentalizing there. And that's the nice thing about this as a treatment modality, is doing it wrong is part of the idea. So that is my talk. And now I'm happy to take any questions.
Great. Thank you, Owen. So while you were talking, there was some chat going on, and I just wanted to highlight one of the questions. One of the participants asked, I guess collectively, are you mentalizing? And I thought that was a good question. I actually said that as the moderator, I am trying to mentalize. So I'm trying to imagine the minds of the participants and what they might be thinking, and if they need clarification on something you said. So anyways, this is just, it's not just for therapy, it's sort of day-to-day life skill. So Were you mentalizing when you were giving the talk?
There were moments where I was not mentalizing and got frustrated when the camera, got wonky or something. And then I thought, well, if we're doing this thing for a live audience, acting frustrated and getting all derailed is not going to be helpful to them. So, maybe I have to drop my expectations of perfection and do a good enough job and kind of simmer down and, restore my mentalizing. But it's an ebb and a flow all the time. It's just for some people, it's more fragile. And you spend more time more easily knocked off balance. I think for people who are good at mentalizing, they're good at getting back up, not so much being perfect all the time and staying in that curious spot. Because frankly, that's not realistic or adaptive to always be curious about everything at all. And you're walking down the street, you got to get from point A to point B, and that means you can't consider everyone's internal world.
Right, that would be exhausting and pointless, and you wouldn't get to where you need to go. So thank you, Dr. Muir. I think that was very, very interesting. I'm hoping that our audience thought so as well. And we do have a couple of questions. So one question is, how did you actually get interested in this in the first place? Can you talk about that?
Well, I met someone named Carleen McMillan, who went to McLean Hospital for her training, and get that off because that's distracting. And Carleen said, "Look, this is amazing. You have to do this training." And I said, "Really? Personality? I'm busy researching schizophrenia over here. This is good enough for me." And then, what I saw was medication failure after medication failure and patients I couldn't help and therapy that wasn't going anywhere. And I actually, and now I can say this out loud, I actually snuck off campus from my adult residency training program. I mean, I had my pager with me. I arranged for coverage, but I went to McLean for this training in a day I didn't really have off. And later I won an award that paid for me to go to that training. So everyone knew I did it, and, dropped it. But I think there was some subterfuge there. And I went and I saw something I'd never seen before, which was people who are British, importantly to me, because I grew up listening to books on tape from the BBC, generates a lot of trust for me. I saw them being able to do things for suicidal patients that I found myself incapable of doing. And it was a real wake-up call that maybe there's this whole world of tools that I didn't have at my disposal. And from that point on, I was kind of, off the deep end and, like most studied, practice. And here we are.
Right. So speaking of studies, can you just say very briefly the Cliff Notes version of the evidence base for this?
Sure. We have multiple replicated randomized controlled trials with effect sizes between 0.7 and 1.7 for all outcome variables.
What's an effect size?
Effect size is the difference in units of standard deviations between active agent and control. And basically what that means is, like, you want to look at the magnitude of the number. Because statistically significant can mean definitely a difference, but it's really tiny, or definitely a difference and it's huge. And with MBT, it's huge. To give you a sense of comparison, Abilify augmentation and depression. Statistically significant, tiny difference, 0.2.
Right, a medication. 0.2.
A medication. Lithium in bipolar disorder is a great drug. That's 0.7. ECT in depression, 0.9. And then we have mentalization-based treatment for people who are chronically suicidal, 1.26. That's a bigger number. And it's held up in multiple trials and multiple populations. It seemed to be an incredibly potent tool. And so, I'm interested in evidence for things that work. And this really works, but it's a therapy. So Janssen can't sell it, make a lot of money on it. And that makes it harder to deliver in our current reimbursement system, which is also interesting to me. But it works great. We got a lot of studies backing it up. That's the short version.
Right. And a lot of those studies, some are from the United States, but a lot is from Europe, where this started, in the UK.
And the Netherlands as well.
Netherlands. Yeah. And so for people interested in personality disorders in the United States, DBT, or dialectical behavior therapy, is something a lot of people have heard of, or they've done. We actually got quite a few questions about, like, DBT compared to MBT. Can you do both of them? Are they different? Like, how do you think about that?
I think so. Everything works for not everybody, for one thing, and different medicines do different things for depression, for example. And we don't only have one medicine, because some people need something different. And these things actually work well together empirically. When we've combined mentalization-based treatment with DBT, we've gotten better outcomes in the studies we've done that. And I think it's different people at different times in the course of their life. If what you need to do is stop cutting, DBT is really good at that. MBT is also good at that. But, they did a really good job of building a model that could reduce suicide and self-injury. And that's important. But what it leaves out is meaningful psychosocial recovery. And so what you don't see is people getting off psychiatric disability with DBT, or getting off, getting meaningful relationships outside the family. And you do see that with MBT.
I mean, you can, but the evidence suggests that DBT is really quite good at putting out what they would call target one behaviors, right? Life-threatening behaviors, but sometimes it's not enough for people.
Yeah.
Right?
And I think Marcia recognized that. I mean, she added the think skill, which is basically mentalizing, to DBT as time went on. So all these things are evolving models created by people trying to figure out what they're looking at and give it back to us in a way we can use.
Right. And they're not incompatible at all. I think that's one of the things with MBT. It's sort of a way of life. I think of it as sort of the Wi-Fi, right? You can do anything on the internet, but you need the Wi-Fi. The way of mentalizing can
I would think Brooklyn Minds, without every other therapy that we use, EXRP, prolonged exposure, DBT, etc., would be not good.
Right. It's the core of what we do, and our whole team really learning it, right? And being, that way. So,
but it's a scaffolding for everything else.
Right. So one of the participants has just asked, does this relate to mindfulness? Because the mentalization, mindfulness, a lot of times when I say MBT, people think I mean mindfulness-based treatment. There's a lot of confusion around that.
My response is it's mindfulness for the both of us. Because usually mindfulness is about being aware of your own moment. Well, what if you're aware of someone else's moment, maybe sort of kind of too? That's mentalization.
Right, keeping both minds in mind, and both are very, I think, here and now. Focused.
Yes, here and now with us is here and now by myself is mindfulness. Here and now with us is MBT.
Right. We also got some questions about family members. So if you have a loved one who's in treatment with MBT, what can you as a family member do to support them?
Yeah. And I think, usually the advice is educate yourself. Unfortunately, there isn't a really good popular press book about this, and there should be. So give me a bit. I think there's some really good resources like on Peter Fonagy's interviews on the Borderline the Film website that Rebbe Ratner did. That's really great material to help people understand what's going on with this. But the nice thing is, mentalizing is kind of infectious. So if one person's in mentalizing treatment in a family, it's gonna rub off on the other people in the family. And not for nothing, MBT for families exists. And so I think there is, getting the entire family into therapy actually is kind of a good idea. And sometimes it's an even better idea than individual therapy.
Yeah, so I think that kind of relates to another question that we got about sort of practicing these skills. Like, it's one thing to read about them or learn about them in individual therapy, but when someone's in crisis or they're with a family member how do they actually practice these skills? How do you get good at this? And I guess you can mentalize my mind where I might be going with this, but what can people do?
Well, I mean, so for mentalizing isn't something I think of as only for experts. And so, mentalization based treatment is really teaching people how to do what we do as therapists. It's not, the therapy supervision we have and the groups we run aren't that different. In fact, some of the groups are pretty advanced in terms of what they're able to do with each other and see these alternate perspectives. And I think keeping some of these basic concepts in mind. Am I mentalizing is the question you ask first, not what can I do about this other person?
Mm-hmm. Yeah,
curious?
You've called the MBT groups the training ground or the dojo.
Because I stole that from a patient, but yeah, time with your sensei is individual therapy, and time in the dojo is MBT group. I think any treatment for adolescents for self-injury, all the evidence-based treatments include family work. There's multi-family group in DBT. There's MBTF in MBT for adolescents. MBTC is family work. In adult models, there's group, right? Because more minds in the room makes it harder. And so it's like, lifting heavier weights in the gym builds up your muscles. What can you do practically? If you're a clinician, recording your sessions and getting ongoing supervision. And that's why I trained as an MBT supervisor. So I'd be on model in the process of supervising individual group, because more people need to learn to do this. But to learn to do this, you gotta take a look at what you're doing and reflect upon it with someone who can help you do that, or someone's, because the supervision model usually involves groups as well. And that's what we do at Brooklyn Minds, and that's what I offer as an MBT supervisor for people externally.
That was going to be my next question. Someone asked about supervision and what that role was. And so it is, it's a huge part. You can't do this alone. When you're so close to a situation, your mentalization as a therapist goes offline. You can't think clearly. You need help from your peers, your co-therapists, to really kind of help you kind of keep things moving along.
Unlike DBT, where the progression, you go to the trainings and you get signed off. In MBT, to progress through the ranks, as it were, to get up to the level of a supervisor, which is, MBT operating Thetan, you actually have to demonstrate being on model in recorded material with your supervisor. So to do it, you actually have to prove you're doing it. And using hearing skills, this and that, it's a pretty arduous process, which is probably why there aren't so many of us.
Right.
That probably needs to be streamlined, but they want to make sure people are actually doing the thing they say they're doing.
So I know we're running short on time, but just quickly, we did have a question about goals during treatment. Can you talk a little bit about like setting goals or sort of the formulation?
Yeah, you don't have to.
What's the goal? The goal is one goal.
The goal is
right?
to mentalize. Yeah. The goal is, what do you imagine the goal is going to be? So formulation is part of that, and that's writing down or demonstrating in some way, and it can be with a synthesizer. Like, how do you feel? Am I getting that right? That's the iterative process. You can literally talk about nonsense, more or less, in therapy for a year. And if you're curious about it, that person is going to get better. And that's the Oracle thing. You don't have to have fancy goals. The goal is process, not content.
Right. So like if you think of what we call insight-oriented psychotherapy, traditional psychotherapy, you go in, talk about your things and kind of come up with reasons why certain behavior happened. That's insight. The goal is to generate those insights, right? That's not the goal with MBT. The goal with MBT is to get that skill so that you can think in this manner throughout your life, which is I think why it's so powerful.
It is, and also like pretty liberating. Like I don't have to come up with any good ideas or insights or anything. I just have to go, I'm not following, and get my patient to get in that same space, and then we're cooking with gas. It gets people better.
Right. So I know we've gotten questions about resources and books, and like you said, there isn't a great popular press book, but I think the book that Owen co-edited with Dr. Laura Williams from Menninger and Baylor has a bunch of chapters from a bunch of people in the MBT world, including myself. And I actually think, it could be appropriate for a general audience, right? I mean, you guys wrote it, edited it so that it would be relatively approachable. Yeah,
we wrote it to be accessible to really, really baseline level therapists, but with the knowledge that family members are going to pick this up. Because
so don't be scared off by the academic thing of it. I think it's definitely, hopefully like today, aimed at the kind of a wider audience. So.
And it does a few things that other MBT manuals haven't, which is look at incorporating with DBT, for example, like we do at Brooklyn Minds, or CBT, or things like that. And that hadn't been looked at before, so we were happy we got to do that.
Yeah. All right. Well, I think that's a good place to end. So thanks so much, everyone, for participating, and go forth and be curious, not knowing, and mentalize. All right.